All right, should I start? Okay. So thanks so much for coming today. My name is Julio Fiore. I'm an assistant professor at the Department of Surgery, and I'll just tell you a bit of my background to introduce myself. I'm a physiotherapist by training. I did my bachelor. I'm originally from Brazil and did my bachelor's in Brazil, and my master's also in sciences I did in Brazil. And then in 2008, I went to Australia for a PhD, and I was there for about 5 years. And I did my PhD studying postoperative recovery after colorectal surgery. And that's how I became really interested in these topics, studying surgical recovery after major surgical procedures. And in 2013, I came to McGill for a postdoc. And we did like a big RCT during my postdoc. It was a very rewarding experience. I think I found myself a very good research group that have the same research interests that I do. And about 2 years ago, I got this position as an assistant professor, and I've been a PI since then, and now writing grants, trying to build my whole lab, the whole field that you guys know very well. So yeah, these are my disclosures. So I'll start this presentation by explaining a little bit about the impact of abdominal surgery and explaining the concept of postoperative recovery. Then I'll go through some recent innovations of abdominal surgery that aim to improve recovery for patients. In the third part of this presentation, I will discuss why measuring recovery is such a difficult task. And after that, I'll explain why patient-reported outcomes are so relevant for surgical patients and tell you a bit about some of the work that we're doing in this field. Then I'll finally provide a brief summary of what we discussed during the presentation. The term abdominal surgery broadly covers any surgical procedure that involves opening of the abdominal cavity. And this includes operation on the stomach, gallbladder, small and large bowels, liver, pancreas, and etc. This patient population is particularly relevant when studying surgical outcomes because, number one, abdominal surgery accounts for the highest volume of in-hospital operations performed in North America. Only in the US, 9 million abdominal surgeries are performed every year. And also, importantly, abdominal surgery is a common cause for postoperative morbidity. And the main driver to these high rates of morbidity is the fact that abdominal surgery is a major surgery that represents a significant trauma to the body. And the body's metabolic response to major abdominal surgery is indeed very similar to the metabolic response to an accidental trauma. Pretty much the only difference between an accidental trauma and a major surgical procedure is that the surgery is a pre-planned trauma with a specific therapeutic goal. And in the case of surgery, this metabolic response is often termed surgical stress response. And as with any trauma, the ultimate aim of this response is to prevent further damage to body structures and also mobilize substrates to facilitate healing. And this response starts from the tissue injury, and this injury causes a chain of reactions mediated by the release of inflammatory mediators, and these inflammatory mediators activates neural and hormonal systems. And these chains of reactions have an important impact on body functions, especially in the early period after the surgery, when patients will invariably experience postoperative pain, postoperative fatigue, reduction in exercise tolerance. Patients also often experience sleep issues and also changes in gastrointestinal function. And of course, these issues with body function will also have an important impact on patients' activity and participation in society after the surgery, with reduction in home, work, social, and recreational activities. So this classic graph represents very well what is expected in terms of health and function after a major surgical procedure, as these patients will invariably experience a rapid and steep decline in health status after the surgery, and this will be followed by a gradual return towards or above preoperative levels of health. And the term postoperative recovery is used to describe this period from the surgical trauma until the patients return to their baseline levels of health and function. In the last 20 years, the field of abdominal surgery has evolved with the introduction of new technologies and also changes in perioperative care. And as I'll show you in the next few slides, we have evidence supporting that these innovations can improve postoperative recovery for patients by reducing the level of tissue trauma and also optimizing perioperative care to enhance surgical recovery. So in comparison to the reality of surgery 50 years ago, this is, of course, a bit of an exaggeration of what we see in surgery today. I really like this picture. I'm not sure if all you guys are familiar with this guy. This is Dwayne Johnson, or The Rock. He's an actor and wrestler. And in 2013, he was submitted to an emergency hernia repair. And this is a picture of him in the recovery room, like a few hours after the surgery. So what I want to highlight with this picture is that something really changed in surgery in the last few years. And what I'm about to show you is how we came from this to this. So there were two main drivers to this evolution in surgical care. One was the use of minimally invasive surgery, and the second one was the optimization of perioperative care using enhanced recovery pathways, or ERPs. So I believe that most of you are somewhat familiar with the concept of minimally invasive surgery, or MIS, which is also known as keyhole surgery or laparoscopic surgery. By definition, MIS comprises a variety of techniques to operate with less injury to the body in comparison to traditional open surgery. And in abdominal surgery, MIS usually means obtaining surgical access using 2 or 3 small incisions and also using a video camera. So as you can imagine, the overall goal of MIS is to minimize surgical trauma, allowing patients to recover better and faster. And of course, MIS also aims to provide cosmetic benefits by improving the appearance of surgical scars after the surgery. So just a bit of history. Minimally invasive surgical procedures started being used experimentally in the beginning of the 20th century, mainly used as a diagnostic tool. And in the 70s, this technology started being used for simple surgical procedures, especially in gynecology. And finally, in the 1980s, with advances in video technology, MIS techniques started being used for more complex procedures. First, for appendectomies, like with the first case described in 1981, and then for cholecystectomy, the first case described in 1987. And nowadays, virtually any abdominal surgery can be conducted using minimally invasive surgery techniques. So in light of all the potential benefits that I mentioned, do we have sufficient evidence that MIS improves surgical recovery? The results from meta-analysis suggest that yes, MIS can improve recovery, at least in terms of hospital length of stay and complication rates after surgery. And these are usually used as proxy measures of recovery. In this meta-analysis, comparing open to laparoscopic surgery in colorectal surgery, as you can see in this forest plot, the average reduction in hospital length of stay was almost 3 days compared to open procedures. And excellent results have also been observed in terms of postoperative complication, with laparoscopic surgery reducing the odds for complications around 30%. And some studies were also interested in evaluating the impact of MIS in terms of patient-reported outcome measures to assess whether, from the patient's perspective, MIS has actual benefits. And the results observed in this literature were quite curious, as you can see in this systematic review from 2010. Although the benefits of MIS seems quite clear in terms of clinical outcomes, studies evaluating the impact of this intervention on PROs found no significant differences. So you might ask, if the benefits of MIS are clinically so striking according to the literature, why don't we see positive results in terms of outcomes reported by patients? This is one of the main topics of this lecture, and I will come back to this topic later.
So, patient-reported outcomes, you're saying they're not good?
Yes, most of the study didn't show significant differences between open and laparoscopic procedures.
In this table here?
Yeah.
What are you showing?
It's showing differences between procedures, like for each specific patient-reported outcome measure used in different studies. And this is just a descriptive table. Yeah. Because it's very hard to meta-analyze data on PROs unless studies are evaluating exactly the same PROs at the same time points. So
Between patient variability, and you cannot measure within patient variability.
Yes, yeah. So far it's very up to this stage it's very hard to meta-analyze data on PRO measure.
I just like to emphasize that sometimes meta-analyses are not the appropriate
Exactly.
Analytical exercise that needs to be done to explore some of what we're looking at.
Yeah, I absolutely agree. Okay, so I'll go back to this topic a little bit later. And as I said, the other concept that really revolutionized surgery in the last few years was the use of enhanced recovery pathways to standardize perioperative care. So ERPs, which are also known as fast-track surgery or enhanced recovery after surgery, or ERAS, which is also a common abbreviation, are defined as standardized, coordinated, multidisciplinary perioperative care plans incorporating multiple interventions shown to improve recovery into one integrated package. And these programs can integrate, in fact, more than 20 interventions used in the pre-op, intra-op, and post-operative periods. Examples of interventions include preoperative education, short preoperative fasting, use of epidural analgesia, avoiding the use of drains after the surgery, and also early intake of solid food and early mobilization. And the theory is that the combination of these interventions have a synergetic effect in maintaining body functions after the surgery, and in doing so, it helps enhancing post-operative recovery. And again, a bit of history. This concept of care was first described by Henry Kellett in 1997. This is a surgeon from Denmark. And just for you guys to have an idea about how revolutionary this concept was, Dr. Kellett and his colleagues, they got a publication on Lancet describing a cohort of only 8 patients treated with his fast-track protocol. At the time, the average length of stay for colorectal surgery patients was between 8 to 10 days, and in Dr. Kellett's cohort, the average length of stay was only 2 days. So this concept came to North America in early 2000. In 2005, we had the first consensus on enhanced recovery after surgery published. And in 2006 marked the year when the first enhanced recovery pathway was implemented at the M.Sc by Dr. Franco Carli and Dr. Lian Feldman. And since then, our departments of surgery and anesthesia have been like extremely research active in the field of enhanced recovery. And we've, in the last 10 years, McGill produced numerous contributions to the ERP literature, including studies on preoperative interventions to enhance recovery, contributing evidence regarding the effectiveness and cost effectiveness of ERPs and interventions within ERPs, and also studying outcome measurement in this context of care.
Interesting, because we've all heard about the number of instruments that are left.
There was a case last week, right? The risk might be a little bit lower, yes.
A little bit lower?
Yep.
Yeah. That would be a great publication. You know?
I think so. I'm not sure about like the sample size requirements to prove this research question, but like.
There's enough laparoscopic surgery going on right now.
Yeah, no, that's true.
Yes?
They leave a pen in.
They leave a pen?
It's still.
Oh, yeah?
It still can happen.
Well, I would think that it would be forward. Anyway, I think that would be an interesting.
Yeah, in open surgery, like, of course. I don't know if you guys watch, but there is an episode of Seinfeld where he drops like a meat inside like a patient's belly, so that probably wouldn't be a risk in laparoscopic surgery. So yeah.
Somebody did a study in the United States. Did anybody read it where they counted the number of surgeries that had things left inside the body? Somebody's done that. Anyway, I think it would just be a
Yeah. We could discuss that further.
Anyway, one thing that you have not mentioned up to now is infection. So, do you measure it? Do you account for it? How does infection come into the pathways?
Infection comes into like as an outcome measure. Usually, like infection can be evaluated as part of like overall post-op complications, but also separately.
Yeah.
And
but it will influence the time to recover.
Yes, absolutely. Yeah, any complication influences the time to recovery.
Everything.
Yes, exactly. As like any post-operative complication. That's. Yeah, most of the RCTs that we do like include complications as an outcome measure, including infection. Yeah. Okay. Yeah, exactly. Okay, so in light of all the potential benefits of ERPs that I just discussed, what is the evidence that this approach actually improves post-operative recovery? This is a meta-analysis published in 2014, and it illustrates really well what is the current state of evidence across different surgical specialties. And benefits were observed in terms of hospital length of stay, with an average reduction of 1 day, and also risk of, again, post-operative complications which were also reduced in ERPs by about 30%. It doesn't, because that doesn't count as a surgical complication. That counts as a total, like an overall outcome of the surgical procedure itself, but it doesn't count as a perioperative complication. When we speak about like perioperative complications, it's like infections or patients having postoperative ileus, patients having postoperative pulmonary complications, and etc. And just as with MIS, studies evaluating the impact of ERPs on patient-reported outcomes also had very inconsistent results, as we can see in this systematic review from 2010, also showing only descriptive results. I'm very sorry, so take my word for like what's there. So yeah, and the majority of the studies didn't show differences between groups when evaluating the impact of this intervention on PROs. In the case of this systematic review, like they considered any type of patient-reported outcome measures, even unidimensional ones, or even like for postoperative pain, for example. So as you can see, like this first like study used the VAS for pain, VAS for fatigue. There were some studies evaluating the SF-36, the studies evaluating condition-specific PRO measures for example, gastrointestinal disease. So yes, exactly. Like I'll soon show a result of the systematic review that we recently completed. That will like illustrate a little bit better which PROs have been used for this patient population. Okay, so as we saw in the first part of this presentation, one important aim of the surgical innovations that I described is to improve recovery for patients. But so far, the impact of these interventions on recovery, of these interventions such as MIS and enhanced recovery pathways, were only demonstrated in terms of hospital length of stay and complication rates. At their best, these measures can only be considered very simplistic proxy measures of recovery because, as we're going to see, recovery is a much more complex construct. So let's take hospital length of stay, for example. Postoperative length of stay represents the number of days that a patient stays in the hospital after a surgical procedure. This measure is often taken as a proxy measure of recovery because discharge from the hospital assumes that the patient achieved important recovery landmarks, such as, for example, ability to mobilize, adequate bowel function, tolerance of diet, adequate pain control, and etc. However, in addition to all these recovery-related factors, there are several personal and organizational factors that will also determine the number of days the patient will stay in hospital. And these may include absence of postoperative support at home, patients not willing to be discharged, or even differences in hospital culture and differences in healthcare systems. So in other words, length of stay is influenced by many non-clinical factors and may not necessarily reflect a patient's recovery status. Another major disadvantage of measuring length of stay is that length of stay only accounts for very short-term recovery and totally ignores what happens to patients after they are discharged from the hospital. And we have evidence from qualitative studies that for patients, the most important benchmark of recovery, it's not the ability to leave the hospital, but being able to perform activities that they performed before the surgery in an outpatient setting. So the use of proxy measures of recovery in the literature reflect the fact that recovery is very, very, very difficult to measure. And this difficulty is related to the fact that the process of recovery is highly dynamic, with changes in health status happening very rapidly, especially in the early period after the surgery. And also, recovery involves multiple dimensions of health, including symptom experience, functional status, and patient mental and physical well-being. And because recovery is so multidimensional, it cannot be easily captured by one single metric. So this brings me to my favorite part of this presentation, why patient-reported outcome measures may be an interesting option for measuring recovery. As I believe most of you are aware, patient-reported outcome measures are defined by the FDA as reports of health status coming directly from the patient without interpretation by a clinician or anyone else. And in line with the principles of patient-centered care, recent literature really advocates that post-operative recovery be measured using patient-reported outcome measures or PROs. And as you guys can assume, like, patient-reported outcome measures are usually assessed using self-reported questionnaires filled out by the patient. The main advantages of measuring recovery using PROs is that PROs allow a broad assessment of health status across different domains of health and allow that you are able to score each domain separately. It also engages patients as the key stakeholders in the recovery process. And also, very importantly, PRO questionnaires can be completed at different time points after the surgery, allowing a better understanding of a patient's recovery trajectory even beyond hospital discharge. So, as we saw in the previous slides, interventions such as MIS and ERPs, although we have good quality evidence supporting the positive effect on clinical outcomes, studies evaluating their benefits in terms of PROs had very inconsistent results. And in fact, it's not clear whether these interventions really have fewer advantages than expected from the patient's point of view, or if these results reflect the lack of adequate PRO measures to assess postoperative recovery. So it was really in light of these uncertainty that we decided to immerse ourselves in the field of PRO development, and we developed a structured research program to study PROMs in abdominal surgery. And the first step that we took in this research program was to conduct this systematic review aimed to appraise the level of evidence supporting the measurement properties of patient-reported outcome measures in the context of recovery after abdominal surgery. This review was recently published in Annals of Surgery. To evaluate quality of evidence in this field, we use the COSMIC checklist, which is a well-established consensus-based guideline to evaluate studies on measurement properties. The COSMIC is for studies on measurement properties, kind of the equivalent of what the Cochrane risk of bias 2 is for RCTs. And another advantage of the COSMIC is that it also summarizes the evidence regarding measurement properties in a way similar to the GRADE criteria. So the checklist evaluates PROs across 9 relevant measurement properties. I won't go through the definitions of all of them for the sake of time, but the COSMIC has a very interesting website. It's very website. It's very descriptive in terms of these measurement properties and definitions. And of the 9 measurement properties that I just mentioned, 4 of these measurement properties are considered minimal standards for using PRO measures in comparative effectiveness research. And these measurement properties are internal consistency or reliability, content validity, hypothesis testing construct validity, and responsiveness. So in other words, if you want to use a PRO measure in a study, this PROM needs to have evidence support at least these 4 measurement properties. So we conducted a very extensive literature search, and in the end we identified 35 studies. We identified 35 studies examining the measurement properties of 22 PROs used in the context of recovery after abdominal surgery. 4 of the PROs appraised were specifically developed for abdominal surgery patients. 12 of these PROs were aimed at surgical patients in general, and were having their measurement properties evaluating the context of abdominal surgery. And 6 PROs were generic questionnaires having their measurement properties evaluating the context of recovery after abdominal surgery. I believe that most of you are familiar with these generic measures. We had some of these generic measures. We had the SF36, the Q5D, the measured by the World Health Organization, PROMs, or at least a short form questionnaire of the PROMs, and also the short form 6D or SF6D. Our results were quite scary, Because we found that the quality of the studies identified were generally really, really poor. And for this reason, evidence regarding measurement properties were mostly inexistent or very limited. This is a summary table of the PROs most commonly appraised, and it shows that even for measures widely used in the literature, such as the quality of recovery 9, 15, and 40, the SF36, and the Q5D, evidence regarding their measurement properties was very, very limited. And most importantly, none of the instruments identified achieved minimal criteria for use in comparative effectiveness research. So what we concluded from this review was that there is very limited evidence supporting the measurement properties of existing PROMs in this specific context of care. This precludes the use of these PROs to support value-based care in abdominal surgery, and therefore further research is required to bridge this major knowledge gap. Any questions while I drink some water?
Back to the slide.
Yeah.
I don't know if I agree with this precludes the use of these PROs.
Mm-hmm.
Because I think the use of PROMs
Mm-hmm.
would add value to surgical care.
Absolutely. Absolutely. We just don't have the appropriate tools at this point. Yeah. We don't have enough evidence regarding the measurement properties in this. Yeah, it doesn't mean that. Yeah. So in light of this huge gap in the literature, we decided to embrace the field of PRO development. We recently received funding from Sages and Merck to initiate this project aimed to develop a comprehensive, conceptually relevant, and psychometrically sound PRO measure to assess recovery after abdominal surgery.
In Canadian population.
No, I'll get there.
Okay. Because I would think they'd be different.
Yeah, I believe so too.
Even within Canada.
Yeah. Our study follows the FDA guidelines for PRO development, which is a major advance in comparison to previous studies in this field. The FDA guideline was published in 2009 and establishes the necessary steps to develop a PRO measure to support labeling claims. And according to the FDA, this development process should comprise 3 major steps. The first one is to use information from previous literature and expert input to develop what they call a hypothesized conceptual framework, describing which dimensions of health are potentially relevant to the concept of interest. The second step, interviews with patients should be conducted to adjust this conceptual framework and also generate items for the future questionnaire. And last but not least, we should use appropriate methods to select items and develop scoring rules, and then validate the questionnaire in clinical cohorts, evaluating measurement properties such as construct validity, reliability, and all the measurement properties that I mentioned. They're covered by the COSMIC checklist. And another major advance in the field of PRO development that we are taking advantage of is the use of modern psychometric methods to optimize item selection and scoring. And these methods include the use of item response theory and rash analysis. And in our theory, we use rash analysis. So in short, these modern psychometric methods, they ensure that the best items are selected for the questionnaire. And also, importantly, it allows that scoring are given in an interval rather than ordinal scale. And this, there's some evidence that this increases measurement precision and also sensitivity to change. And also, very importantly, these methods provide a basis for computer-adapted testing. I don't know if you guys heard about it, but when you use CAT, computer-adapted testing, questionnaires are tailored to the patient's level of ability because it accounts for the response of patients to the initial items and the questionnaires to choose which items will be presented to the patients afterwards. And this makes the questionnaires much shorter and reduces response burden.
Give us an example of vertical level rather than vertical.
No, I don't think so. Like most of the scoring rules for like traditional PROs are given in an ordinal level, and you don't know exactly if a patient is responding to the SF36, for example. Exactly. You don't know exactly, like if you scored this questionnaire in a scale from 0 to 5, you don't know what's the distance between like 4 and 5.
So how does that be translated into interval level score?
Using RASH models, for example, the model it models the relationship between the patient's level of ability and a level of difficulty of the specific item. And in doing that, it transforms the score. The score will be still like given by the patient an ordinal level, but it will be when you apply the scoring rules, it will be transformed in a numerical level. I don't have it here, but I can send you some literature after. Yeah. Yes. Yeah. 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 Yeah.
No, that's what I was thinking.
Mm-hmm.
I can't visualize it.
Yeah. So you choose the items for a questionnaire based on whether or not the item fits the RASH model. So and then based on that, you're able to do these transformations. Cool. I can give you some examples. There's a very interesting paper on Lancet Neurology. Yeah, there's a very interesting review paper on Lancet Neurology that like explains all the basics about like rationalis and item response theory, and I'll be happy to share this paper with you guys. All right, so this is a 3-year project that has been conducted in 3 stages. Stage 1 involves mainly qualitative work to develop the conceptual framework of recovery and generate potential items for the future questionnaire. And the first step in this first phase was to develop a hypothesized conceptual framework of recovery based on information from previous literature and also expert input. And this paper has been recently submitted for publication. So to gather information from previous literature, we used preliminary data from the systematic review that I just mentioned. And we conducted a process called content analysis to identify which domains of health are covered by the patient-reported outcome measures identified up to 2015. And of the 19 PROMs identified up to that point, 18 were available for content analysis. And we conducted this analysis according to the ICF, which is the classification system of health and function by the World Health Organization. And this was a very long and tedious process, I can tell you, where we had 2 researchers mapping each item of each questionnaire to the ICF framework, and the 2 researchers did this analysis independently, and then we compared the analysis, and all the disagreements were resolved by consensus or by a third investigator. And in the end of this process, we had a list of 42 health domains covered by the 18 PRO measures, and we accounted this as the domains of health that are potentially relevant to the process of recovery according to the literature. And then to receive expert input to this hypothesized conceptual framework, we conducted a Delphi study to evaluate the extent to which experts agree that the domains of health identified in the systematic review are indeed relevant. And this Delphi process was conducted in 2 rounds. In round 1, experts rated how many experts? We had 26 experts. Hold on, I'm getting there. And so in round 1, the experts rated their agreement to each health domain using a 4-point Likert scale. And then in round 2, we gave the experts were given the opportunity to view the results of round 1 and re-rate their agreement in light of their colleagues' responses. And at the end of this last round, each domain were deemed as relevant if at least 75% of the experts agreed that this domain was important. So we invited to participate in this study board members of major surgical societies in North America and Europe. I'm very sorry that I don't have the slides specifying which countries these experts were from. Yes, yeah, I do agree with that, yeah. And
the problem wouldn't be so much that they're finding from countries, if it would then be finding from PRO. But once these PROs are put in the literature and then the finding from countries speak for global, that's when it becomes a little more problematic.
Yes, we are accounting for that in the future stages of PRO development, but for developing the hypothesized conceptual framework, we did not account for that. Because the main aim of this hypothesized framework is to help us developing the interview guides to undergo the. Yes, so that's it. But we're using this to guide the interviews with patients, and interviews with patients are being conducted in different countries, including low-income countries. So if some concepts come up during the interview, if they are not in the hypothesized framework, they will still be in the final framework.
How common are the laparoscopic procedures with low?
It's way less common than here. In colorectal surgery, for example, here the M.Sc, 80% of the cases are done laparoscopically.
8%?
80, yeah.
In low income?
No, 80% here at the M.Sc, yeah. In low income.
If it's if the population that's studied is really relevant, then potentially the could be not.
No, but this is the development.
Yeah, it targets both open and laparoscopic surgery, yeah.
No, fair enough, but it's understood. But the rationale that you put forward was basically indicating that the current measurement tool to evaluate recovery those procedures do not identify a significant difference, or again, the measurement does not differ whether it's open or laparoscopic. That was the whole premise, at least that I understood, to pursue this kind of a research theme, right?
I think this is what made them discover that the current instruments are not good. So now they've developed an instrument that will work, right? And
that's the goal, for sure.
The point and the critique that was provided by you is to say that it's not good or we don't see a difference is problematic to begin with, right? Because again, the comparison is between different populations. The same tool is applied in different populations, and the measurement cannot really decipher whether it's a different outcome in the same patient. That's the problem.
It is not.
To begin with,
it depends on the context that you're using the tool. If you're evaluating the tool in an RCT, we're doing even a multi-center RCT, your randomized patients who will undergo open surgery and laparoscopic surgery. Yeah.
Fair enough, but again, but were the papers that were included in this
systematic reviews,
review were all RCTs? I would assume not. I would assume that there was observational.
Yeah.
So, okay. Don't,
Yeah.
let me not hijack this discussion.
Okay.
It's yours.
So, yeah, so then like after the second round of the Delphi process, we had like 24 experts participating in the Delphi process, and these experts agreed that 22 health domains, 8 related to body functions and 14 related to activities and participation, are relevant to the process of recovery after abdominal surgery. An example of body function domains include energy and drive function, which includes postoperative fatigue, sleep function, pain, defecation functions, and also muscle power functions. And examples of activity and participation domains include carrying out daily activities, changing body position, walking, driving, dressing, remunerative employment, sorry, I can't say this word with my accent, but work activities, and recreational and leisure activities. So, with this hypothesized conceptual framework in mind, the next step, which we started a couple of months ago, involves interviews with patients to develop a final conceptual framework of recovery and underpin the generation of items. And these interviews are being conducted internationally to ensure that we have input from patients with different cultural backgrounds and treated in different healthcare systems. And we have centers in Japan, Italy, Brazil, US, and of course Canada being part of the study. We're going to initially target a sample of 30 patients, 5 from each international site and 10 in Canada, 5 francophones and 5 anglophones. But the recruitment will continue until thematic saturation is reached. And another interesting thing about our study design is that patients will be recruited based on what is called a quota sampling method to ensure that we include patients representing different demographics, clinical and surgical characteristics. For
five francophones and 5 anglophones in McGill are going to provide.
This is a qualitative study, like sample size. So, like sample size requirements for qualitative studies like are purely based on thematic saturation. It might be that this won't be enough, but like the thematic whether or not we achieve thematic saturation will tell us whether or not.
Well, I will say to the same thing potentially, some of the people considering this. I mean, again, how is this going to generalizable to the entire computer? Wouldn't it have made sense, I mean, just as a starting point to get, say, a greater number in a single center, and then go and validate it elsewhere to ensure
that would be another approach, but like we're following like recommendations by the FDA, and it's also like another recommendation by sport that like you start considering like cross-cultural differences from the onset of like the PRO development process. Like the initial version of the PRO will be like developed in English, and then afterwards we're going to do the cultural and language translation to other languages and context of care. Yeah. Yes. Yeah. No, I agree with that. And like so that's it. We are not like aiming to have a questionnaire that is procedure specific. We want to have a questionnaire that targets the surgical. Yeah. That's the main reason why we're using this quota sampling method to try to have like a broad range of surgeries and demographic characteristics from patients. But I agree that this sample size like looks weird, but like this is the initial like sample target that we have, and like it's really thematic saturation that will tell us whether or not this sample was enough or not.
I'd love to define anglophone in Montreal.
Yeah.
Who's an anglophone in Montreal? I don't know.
Yeah, like I don't remember exactly the definition, but like it's people have English as a primary language at home. Like, yeah. Probably you guys are much like, I'm not from here, you guys are much more familiar with that than I am. Yeah. Yeah.
It's like they're looking for that kind of variability across the participants,
The more variable, the better.
Because based on what you mentioned, the quota sampling method, you want a whole mix of participants.
Yes.
Whether the mix is representative or would capture the mix of the population, that's what the challenge.
Why would you end up with a all is basically my question.
I'm sorry?
Well, that's true. I mean, you end up with a representative because it's not representative. I think that this is the first step.
Yeah. Yes. Yeah. Yeah. So the first phase of the study, the qualitative phase using interviews and like forming the conceptual framework of recovery and underpinning the generation of items, this is what will bring evidence of content validity to the tool. And like the only aim of doing all this background work is like to be sure that your tool has content validity. It's hard to like make it perfect because like of course like there are several like variables that like might influence how patients like answer the question that you have during the interview. But the interview like is really targeting the process of recovery from surgical trauma. So like we're not asking any questions regarding the impact of specific surgical procedures, like the impact of like having a lower rectal resection, because like this will bring like other implications to patients in comparison to having a laparoscopic cholecystectomy, for example. But we are trying to account for all of that in this, like using these cholecystectomy methods.
I guess the point at that point it was already for study is not the issue of repeated measurement. So if this is a single measurement truly representative of the experience, or what interval from the procedure will you be administering the tool?
This is something that we are asking the patients. What would be the best like time intervals to give them the questionnaire, so we have like a good representation of the trajectory of their recovery. It might depend on the type of surgery, yeah. Yeah, it might vary, yeah. We're recruiting patients up to 3 months after the surgery, but we have different quotas for different time, different like post-operative periods. So it's like we have quotas for like inpatients, quotas for outpatients, quotas for patients within the first week, the first month, and after the first month. Based on OR lists. So yeah. We don't random, but like we are targeting the patient based on specific quotas. So like now we started some interviews already, and we have like this Excel spreadsheet saying like which specific quota was already fulfilled, and then we look for the patients that might be needed to fulfill the quotas that were not like fulfilled yet. Yeah. All right. So these interviews will be used to inform the final conceptual framework of recovery. And we also underpin the generation of items for the future question, as I previously mentioned. And after a series of cognitive debriefings with patients to ensure that they understand the meaning and the content of each item, we'll have a final pool of items that are candidate items for the questionnaire. And this will hopefully represent all the domains of health that are considered relevant to the process of recovery after abdominal surgery. And with this item pool in hand, the second phase of the project is to have these items tested using rash analysis. And to do this, we have to administer this item to a large cohort of patients, probably around 300, the sample size requirements for rash analysis. And through this process, we'll be able to select the best items and also group them into appropriate domains, and also develop scoring rules to score these domains. And then finally, in stage 3, we'll undertake further assessment of measurement properties of the final questionnaire in a validation cohort. And at this step, we'll evaluate all the other measurement properties apart from content validity. And in the end of this long 3-year process, we expect to have our recovery-specific PRO measure ready for using research and clinical practice. So as you could see, the process of developing a questionnaire is quite complex, but the most exciting thing that we can do is what we can do with this questionnaire in the future. So, of course, as I mentioned, this instrument will hopefully will provide a sensitive, patient-centered measure of recovery to be used in comparative effectiveness research of innovations in abdominal surgery. And I also didn't mention much in the presentation, but the use of PROMs in clinical practice might also provide several benefits to patients, to the healthcare system. So in collaboration with SAGES, we plan to create an initiative to encourage the collection of PRO data in routine clinical practice. And to facilitate the process of data collection, we aim to create platforms to allow remote data collection through mobile phones, tablets, and web portals. And finally, the ultimate goal is to have this information transmitted seamlessly to healthcare centers and incorporated into electronic medical records. And we are still a long way from there, but that's the ultimate goal. And a little bit about the potential benefits of using PRO measures in routine clinical practice. This data can fill a need for patients, caregivers, and payers who commonly seek information about how long it will take to recover back to normal for safe reassumption of leisure and work activities. This data can also assist self-management by empowering patients to track their own recovery trajectory in real time and identify complications at a point where they might be more easily treated. And PRO data can also be used in pragmatic studies to assist decision-making, measure provider performance, and also inform quality improvement initiatives. So, just summarizing the presentation, abdominal surgery represents a significant trauma to the body. The metabolic response to this trauma, which is called surgical stress response, impacts body functions, activities, and participation of patients after the surgery. Recent innovations in surgical care, such as MIS and enhanced recovery pathways, have contributed to improve postoperative recovery, but benefits from the past perspective of patients is still uncertain. And we really believe that the future is bright for the use of patient-reported outcomes in abdominal surgery. That's it. Thanks so much. Any more questions, remarks, critics?